is yet to join us. He might join remotely. But as we wait, I'll So good afternoon, everyone. My name is Kozis Yambo, and I will be facilitating this afternoon session. And I will be joined by Professor Mulenga, who gave us an update on COVID response, number of issues. And today we're going to look at also at TLD, TLE transition, and then we'll look at also people living with HIV and the COVID-19 response. Then we'll have a look at a few literature review cases that are said regarding COVID and pregnancy. And so before we start, I'd just like us to go through a few etiquette issues that we need to understand as we are connected in this network. So we would like to appeal to everyone to keep their devices on mute and make sure that you only unmute when you have to say something. You've been asked to make a comment. So when you want to make a comment, you can go to the chat box and raise your hand, or just wave and we'll try and catch you. Then the other thing that we also want to be very cognizant of is that we are social distancing, and so please do observe social distancing in those places where we have more than one individual. We are requesting that you please make sure that enough ventilation in the room and well separated apart. Thank you very much. And so avoid the necessary movement. It actually has, it is quite disruptive. All right. Thank you so much.
Good afternoon, Dr. Ziambo.
Good afternoon. Thank you.
Sure. I wanted to ask, these slides which are being presented, where can we access them? Slack has been having challenges to upload them.
All right. So we'll discuss with the IT on how they can make it easier for you to access them in Slack. If not possible, then we'll see how we can get on the emails. I don't know, that might be a bit of a challenge, but we'll try and make it available for you. Thank you.
All right, Doc.
All right, so as we wait for the Prof, we'll go through some the poll questions, and then we can get to the discussion. So I will share the poll questions that we're going to have this afternoon, and then we can all pick the best answer. So the first question is about people living with HIV and COVID-19. Which test statement is not true? So which of these statements is not true? The outcomes of COVID-19 in people living with HIV are well understood. B, low CD4 may lead to poor outcomes of COVID-19. C, people living with HIV not on ART may have poor outcomes of COVID-19. D, in people living on ART, living with HIV on ART and high CD4, immunosuppression is not the only concern. So we can actually see and pick a best answer from this. Which one of the following is not true regarding people living with HIV and COVID-19? I've seen there's about 120 of us connected to the network. So we are expecting very good participation on this poll. And so it's very important that we all participate and get active. And so far, we only have about 29% participation. Would you please click on those, pick something, at least and guess. I remember one of my lecturers would say, if you don't say something, I won't give you anything. If you say something, I'll give you something. I'll find something. So please do guess if you can, of knowing what is not correct. Okay, so it's been a minute and 50 seconds, so I'll end the poll. Welcome, Prof.
Social distance.
Yes, certainly. That's what we believe in at ECHO. So please welcome Prof. Mulenga is here with us, and he will soon begin his presentation and he will introduce himself. Prof, we've already started doing the poll questions as we're waiting for you. So yeah, so we'll move on to the next poll question. So the next poll question, and question 2, Mr. SB has been on TLD for 8 months. He was initially suppressed on TLE until his switch. He has 4 months supply of TLD according to the interim guidance. What would be the appropriate next step? A, supply him with 6 months of TLE immediately. B, supply him with TLD at his next visit. C, allow him to complete his TLD supply, then switch to TLE with 6 months supply. D, allow him to complete his TLD supply, then switch to TLE with review at 2 weeks after the switch. So we are inviting you yet again to pick your best answer. And this particular poll is addressing what we'll be talking about today. And that is the TLD, TLE guidance in view of the COVID-19. So if you don't know the answer, don't worry about it. Soon learn. And so this is just part of a learning point for us to be aware of. Okay. We're expecting people to call. And pick the best answer. So thank you so much. I will end the poll here, and then we'll do the next poll question. Third question, and I'm going to launch it just now. So the next question is a true or false. So in COVID-19 interim guidance, the Ministry of Health has advised that HIV prevention services must be temporarily stopped. Is this true or false? Is this true or false? So most people think that this is a false statement. We will be able to find out what the actual true statement is as Prof shares later on. Okay, so I'll end the pause right here, and we'll move on to the next poll question. Poll number 4. So on this particular one, we're trying to find out a few things regarding pregnancy and COVID-19. So COVID-19 does not appear to have worse clinical features in pregnancy than in a general population. Is it true or false? So for this one, it seems there's a 50-50 sort of opinion across the network. Most people ask what seems to be hanging in the balance. We continue to appeal that those joining in, please put your devices on mute. Thank you very much. COVID-19 does not appear to have worse clinical features in pregnancy than in the general population. Is it true or false? Okay, I will end the poll in just now. Then we can share the final question. There is a possibility that COVID-19 can be transmitted from mother to child. There is a possibility that COVID-19 can be transmitted from a mother to a child. Is that true or false? This is another one which appears to be a 50-50 situation in terms of opinions. Thank you very much for participating. This is what makes this Eco Family very good. As we share our best practices, we're able to interact. So thank you so much for your participation. I will end the poll right now. Thank you. And at this particular time, we're going to get back to the polls and then we'll discuss the final answers. And I'm just going to ask Prof to just introduce himself and then he get on with the presentation. Prof.
Thank you so much. Good afternoon, team. Lloyd Mulenga from the Ministry of Health and Infectious Diseases. I'm part of the team leading the clinical side of the infectious disease clinical management. We, as you know, have set up some guidance over how to manage our clients during this time of COVID-19. And also, we are aware that services may be disrupted, and we needed to give some guidance on how should we proceed during this time. We have done so well as a country in the fight against HIV, and we believe that moved together and applied the same energy, the same enthusiasm, and also the same direction in terms of both technical and also leadership, political leadership. We think that we can also even defeat this COVID. As many of you know, we have a number of cases now to 35. And of these 35 cases, we're even now seeing the local transmission. Of those 35, so far we know there's only one who's HIV infected, HIV positive. Don't know how, again, as we proceed, how the outcomes are going to be. Who are on the copper belt, then the rest are in Lusaka. Most of them are doing well, except one. And we also need at this time to thank the people who have been really in this fight so far. Those that have been going out to test, those that have been out there trying to arrange for logistics to be available. And also we have even now about 38 healthcare workers, nurses, they should be about 26 or so. We have doctors who are just in the hospital in Levi and also Masaiti as well. We have medical scientists, We have laboratory technologies as well. And these are really looking after our people 24 hours. And we are stationed there. I can imagine these people are going to be there for a month before they even get out of bed. We know that the conditions may not be the best. The needs is committed to them. But also for the health workers who are out there, you may not be directly fighting this pandemic, but we know that you're fighting as you are trying to prevent yourselves from getting and also other people from getting. That's also a fight. We believe that we are together in this fight. What we want to briefly look at is to see the clinical course of HIV, COVID, people living with HIV, and also look at what the guidance is from the Ministry of Health, especially regarding the dispensation of ARVs. And also we look at the pregnancy. Are there outcomes that may be different in this population? There is a lot of information that we do not know about COVID-19. First of all, just in those who are HIV negative, the general population, there's a lot that we need to know. Now, when it comes to the subpopulations, people living with HIV, there is no data out there on how those who are HIV infected can progress if they have COVID-19. So far, what we know about COVID is, of course, that the infections are severe in the elderly, but also those with underlying conditions like hypertension, diabetes, pulmonary diseases as well. In fact, one of the patients that we have who is not doing, the one who has severe infection, has an underlying condition of some chronic lung infection before he got this COVID, likely from South Africa. Is the others who haven't had any lung disease, no one else has lung disease, chronic lung disease, they're doing well. So again, you can tell from there that pulmonary disease is a risk factor for poor prognosis as COVID-19. Then also we can learn that from the SARS in 2002 and also MERS in 2012, these were the other diseases caused by the coronavirus. We saw that we can assume that those patients that have low CD4 and those who are not on treatment may have worse outcomes. So we really need to guide the people who are living with HIV with appropriate messages and also the staff so that we can at least save this population. We also know that those people who have a viral load which is not suppressed and also those that have CD4s which are low, 100, they're at risk of getting, below 200, they're at risk of getting the influenza, TB, then also the bacterial pneumonia, focal pneumonia, PCP, likely those with lower CD4, 100. But also, what we know is that this COVID-19, it affects the lungs, causes the pneumonia. Once it causes the pneumonia, when you have clogging of the pneumocytes, the lung cells, then someone develop the acute respiratory distress syndrome. Now, that syndrome is also a fear that you may have a hyper-inflammatory response because of pulmonary immune activation. And that is what they call the cytokine storm. Dr. Frick, was it a few days ago, we're discussing like this patient we have with HIV infected, should we give him drugs which can lead to iris and also that cytokine storm? Just a severe hyper-inflammatory reaction as well. So those things we are looking at them for HIV. But also we know that these people are immunosuppressed with HIV, the lung inflammation there, and also you have decreased pulmonary function. And, they also are likely to have other inflammatory responses going on in the heart of the cardiovascular system, and also just when you compare them with other people of similar age with no HIV, they are more frail compared to those who don't have it. And if combined with the smoking and also other inhaled substances can be common, we think that these may have worse outcome. As a result, we came up with interventions which are meant to protect the people living with HIV. And in these interventions, our goal really is to have less frequent visits of the people living with HIV to the facilities because they will be congested there. And for someone who may have COVID, then the risk of transmission will also be quite high. First thing which you should emphasize is that ART services will continue. Provision of ARVs are going to continue. Of course, there will be modification in certain. But also, as more information comes out on people living with HIV, we may give certain directives so that we can protect this population. Our priority is to prevent and also contain COVID-19 in the people living with HIV. Just before I came in, I received a call from WHO. People are interested in finding out the number of patients with HIV we have, COVID as well, and also see if we can part of the larger group better on the outcomes. So this was done.
Done this one. So,
Right. We know that we have already shipments of TLD have been delayed by a month. We may also have, I think, shipments being delayed further. Right now, the airlines are shutting or they are canceling their flights into the country and just the country regionally and also globally. So we fear that with the supplies which we have of TLD, they may even be worse in the coming months if we don't do anything. We currently have, if you consider the number of patients that we have on TLD, we currently have just slightly over 2 months supply. Need to know if late last week we received the other supplies which we were expecting. But what we know is that the TLD supply globally is being affected by COVID. Initially, we were told also from the some of the active ingredient, which is a pharmaceutical active ingredient in the drugs, coming from China, and when China was hard hit by COVID, there was also reduced production of DTG, which is part of it. So because the other point I emphasized was we don't want our people living with HIV to be exposed to COVID-19 infection. We are now enforcing that all those patients who are really stable, and most of our patients, more than 90% are stable, supply them with 3 or 6 months of ARVs. But also, we have supplies for ARVs for TLE, which can last us at least for 4 to 5 months. And with this supply which we are immediately recommending all the patients who are on TLD, when they come in for a refill, we give them the TLE supply for 6 months. If we do this, then we are going to have at least more products of TLD accumulating. And as they accumulate at a necessary point, we are going to give another instruction for patients to switch. We are now going to also emphasize that those who are being initiated, they should be initiated on TLD or PLHIV as per national guidelines. So the initiation should not be on the TLE. And another point is that only those patients who have been on TLD for more than 6 months are the ones who should be switched to TLE, because we want to at least make sure that they are fully suppressed before we switch to TLE. Now we know that also we have a number of clients who have TB and also diabetes. And again, this should be in line, like if someone, even those who have on TB, have agreed that even the TPT should be provided according to the months that someone is coming to get the drugs for the ARVs. Someone is getting a 3-month supply of ARVs, then you should also give the TPT similar as well, 3-month supply, so that they don't have to come in the business. Then viral loads as well should be performed as per national guidelines, so they need to come for either yearly, those that are yearly viral loads, or 6 months for those that need to have the viral load done at 6 months. In those who are failing treatment, the next adherence counseling should be done, but they should be given a supply of 3 months. And then when they after 3 months, that's when we should be able to repeat viral loads. In the meantime, the next adherence counseling should be done by phone or any other interaction. For PrEP as well, they need to receive the 3 months of TL or TE, and also monitor the clients by phone, both for adherence and also side effects. It should be a combination package, of course. The condom use and also STI screening should be offered as well. And the appointment system should not be given to more than 5 times per block. We're trying to at least reduce the number of patients or clients that may be. Similarly for children, 3 months monthly scripting as well should be done. Those 2 to 10 years, but those above 10 years, it should have said 6 months for those above 10 years. Then in the meantime, you should adhere to have the maybe C3G, CPG for those above 20 kg, and generally tough ED for those above 25 kg. Children above 25 kg, tough ED, and those above between 20 to 25 ABC3TC. We have Dr. Foloshi there to be consulted, and also Dr. Sibile. We need to now, Dr. add your name there. There are a lot of pediatric issues coming.
All right, thanks.
So
We'll put
Dr.
my name on
Koja's,
it.
the name should be there and his phone number.
We'll do so, Prof.
Maybe some of you don't know that this man is now in HIV. He's a pediatric co-mentor for HIV, the Ministry of Health. So any technical issues relating to pediatric HIV is the man whom we need to consult, authority, together with other set of clinicians. Working closely with the pediatric team, Dr. Montali, and other pediatricians as well. He's the one to contact, that's why his name has to be there.
No, thank you so much for finding your central.
Oh my God, he doesn't need it to. In fact, if I needed to go there, then I was supposed to mention even the twins he has.
All right, thank you so much, bro.
Thank you, Phil. Thank you. So related to pregnancy again. So pregnancy, the outcomes as well, we don't think that the people who are pregnant may have worse outcomes as well. But we have seen mother-to-child transmission. One child tested positive for SARS-CoV-2, which is the virus which causes COVID-19. Then also there is another child at 30 days was also tested positive as well. So really, we think that there may be mother-to-child transmission of SARS-CoV-2 from an infected mother and one child. It may be either in utero or it may be during delivery as well. But we have, of course, a statement that women do not appear to be at higher risk, the pregnant women, progression of severe disease. And as seen in that study, which I think we are going to have access to, 147 pregnant women, 64 were confirmed, 82 suspected, and 1 asymptomatic, and 8% had severe disease. It is in line really with what we see in the other institutes and the general. We do not have any, for the Zambian cohort, we don't have any HIV infected, or any pregnant woman with COVID. We have one whose wife is pregnant, and we are hopeful that it's not going to transmit to the wife. But so far, there's no fear for worst outcomes for those that are pregnant in terms of COVID infection.
Right, so thank you so much, Prof, for this very enlightening information that will help us in our response. And indeed, we continue to appreciate the health workers that are currently at the center of managing these COVID patients admission. And so we'll get back to our polls so that we can go over some of the learning points that we thought we needed to have in this session. So I will relaunch the questions from the top, and so we can so that we can go through together. Afterwards, then we will allow for any questions that the network has. So the first question about people living with HIV and COVID-19, which statement is not true? And so we have the outcomes of COVID-19, people living with HIV are well understood. Low CD4 count, CD4 may lead to poor outcomes of COVID-19. People living with HIV not on ART may have poor outcomes of COVID-19. Then in people living with HIV on ART and high CD4, immunosuppression is not the only concern. So I think this did come out in the presentation, and so we are hoping that people can select which one is their best answer option. For Prof, we have got people about 70% of the respondents think it's outcomes of COVID-19 PLHIV are well understood. All the rest,
They think they are well understood.
Yeah, that's not that. I think that's not correct. Yes. Yeah. So I'll end the poll and then we can discuss the final answer on this one. Share the results. Prof, your comment on this?
I think majority of really answered well. And then
so the next poll question, Mr. SB. So Mr. SB has been on TLD for 8 months. He was initially suppressed on TLE until, he was initially suppressed on TLE until his switch. He has 4 months supply of TLD according to the interim guidance. What would be the appropriate next step? So this is a man, 8 months on TLD, was switched after TLE, but was well suppressed at the time of the switch. He has 4 months supply of TLD. According to the interim guidance we've had this afternoon, what would be the appropriate next step? A, supplying with 6 months TLD immediately, supplying with TLD at his next visit, allow him to complete his TLD supply, then switch to TLE with a 6 month supply, allow him to complete his TLD supply, then switch to TLE review at 2 weeks after the switch. These are very common scenarios that we will be meeting in our practice as we continue to see our clients during this time. And so this is a very an ideal situation that we might encounter. So we're trying to see what sort of action we're going to take. A number think that they think C is the best option, that just to allow them to complete the TLB and supply the switch, then switch maybe once the TLB is.
So what do you think? Right thing to do, not so?
Yes, this sounds like C is the right thing to do. Okay, so the C is the right thing to do. Any comments on that, Prof?
Yeah, remember we are trying to want to have, already we are interrupting these patients, these clients, we are really doing something. Thankfully, we have received so much support from the HIV, the network, and but next week they will be in the ground also trying to educate the people there. This switch is because of the COVID-19, and we are hopeful that even our clients are going to respond appropriately. So far, many of the interventions which we have done as the HIV program, Zambian people have been responding. And even in this time, I think they will be able to understand. However, we should minimize as much disruptions even to their lifestyles. Let them complete what they have. And when they come back for the review, when we give them.
Thank you so much. I think the emphasis is to minimize as much as possible the interruption in their treatment, except when they have to come back for the next review. So we move on to the third poll. In COVID-19 interim guidance, the MOH has advised that HIV prevention services must be temporarily stopped. I think this is an emphatic no, eh? This is false. I think that was the first statement that I think Prof made. And we still have someone who thinks it has been interrupted. Yeah. Okay. Thank you very much to the network. I think I'll end the call for this one. The answer here is very obvious. We still need to provide the services as given in the guidance. So we will move on to the next poll question. COVID-19 does not appear to have worse clinical features in pregnancy than in the general population. True or false? I think towards the end, Prof did actually highlight a few things, a few studies that have been done, and a number of patients that was in China, and they reviewed a few some information regarding COVID in pregnancy. So we still have about most people in the network think that COVID-19, the A is true. So we'll end the poll here. Just a few more minutes, sorry, a few more seconds, and there we got. So I will share. So most people think that this is a very correct statement. COVID-19 does not appear to have worse clinical features in pregnancy than in the general population. Yes. Yeah.
Now for those, how many?
About 20 participants. It's a learning process. And so we'll go to the final poll question. Yes. So there is a possibility that COVID-19 can be transmitted from mother to child. True or false? This was the last statement, I think in the last slide, second last slide that Prof presented. I think we don't have anybody voting. Are we still connected?
We are connected. No one wants to vote. Dr. Follow, she can't vote.
We have a problem with the was relaunching it. Okay, so I think we had a problem with technical hitch on that last poll. So the question is, there is a possibility that COVID-19 can be transmitted from mother to child. Thank you very much for participating. You can see people have voted. Most of them think that this is a true statement. And, I think indeed, Prof did highlight during the discussion regarding this. So I will end the poll here, share the results. So the first statement, I mean, the test statement is actually true. And so we do appreciate participation from everyone that was in the network. At this particular time, we are going to invite the network to ask some questions and anything that you would like and would like to see clarified from the presentation that Prof has made this afternoon regarding the guidance on how we're going to manage people living with HIV in this current pandemic situation. So we open up to the rest of the network. So you can raise your hand, you can lift your hand using the sign on the chat, then we'll be able to respond to you. Okay, so we've got 2 hands. So we'll ask Patrick to go ahead and unmute yourself so that we can. Patrick Kawe.
Hello.
Yes, Dr. Kawe. Go ahead.
Hi, Kozia. How are you, Prof?
I'm all right.
How are you?
I'm okay. This is Dr. Patrick Away with Africa CDC. Yeah, so great presentation there and a great pause that you are conducted. I think for me, I'll speak on the epidemiological point of view because I know you guys have concentrated more on the clinical aspect of this important discussion. I'll still zero in terms of COVID-19 in pregnant women. I think apart from the clinical aspect of it, and I think it's just important that I think the network which is here, they should be able to know how to handle when a pregnant woman comes to the facility. And I think that is quite key. What are they going to do when a COVID-19 patient comes to the facility? So basically, maybe I'll just put it in yeah, so I'll basically put it in about in a six-fold. I think what everyone would need to understand is once you have a COVID-19 patient, the first thing is you need to ensure that you do a rapid assessment. I think that is quite key. Do a rapid assessment, and once you do that, you need to ensure that you do your IPC. Very important. So if this pregnant woman comes in with suspect signs and symptoms of COVID-19, of course, the basic things need to be done. Standard IPC practices. Of course, you need to give the client a mask. You need to apply droplet contact precautions. And I hope our healthcare workers, I think they've gone through all these trainings, whether they're online or probably physical trainings that have been conducted in Zambia. So you need to ensure that the IPC adherence is actually done. And then the next step in any pregnant woman, I think you need to ensure that you assess the severity of the signs and symptoms. Okay, and we know the severity is you need to see if the woman has got difficulties in breathing or shortness of breath, if they are gasping for air when they're talking or standing, if they're coughing blood, tightness or pain in the chest. So you look out for such kind of things in any pregnant woman that comes to your facility. And of course, you need to assess for the clinical risks for serious complications, which I think Prof has actually mentioned. You know, issues of comorbidities and all those things. You need to ensure that you look out for those things in pregnant women. And the other thing is you need to now assess the epidemiological risks. Okay, so when you say epidemiological risk, you need to assess 2 days before and up to 14 days. Were they in contact with any confirmed or probable case of COVID-19, or did they travel or to a country that is affected with COVID-19? So once that is done and you are sure that is happening, of course, now you know that you need, I'm sure there are all these SOPs which are available and know who to inform about such. Okay, and of course, finally, you need to ensure that where to send this client, a pregnant woman, for testing. And once that is done, each pregnant is supposed to get the exact postnatal care, post-abortal care, and everything else that we normally do. All the routines need to be done, even in a COVID patient. So there shouldn't be any like we know some of the standard things that we do in terms of in terms of postnatal care. So all the standard care need to be taken into consideration. All right, and of course, in terms of delivery, it's the usual. You need to ensure that a woman delivers, via a vaginal delivery, and if it's cesarean section, of course, you can do some of the process which we term they can generate some aerosols, and you need to up in terms of your IPC. That's when probably you might even need an N95 mask and all those things. So whenever you're handling any fluids and those things that can happen during delivery of a pregnant woman, you need to ensure that your mask, you need to use an N95 mask. You put on your waterproof long sleeve gown and all those things. So all those things need to be put into consideration when dealing with a woman with COVID-19. But the most important thing is you do your risk assessment. You assess the woman for any suspicion that this could be a case of COVID-19, and you follow through to a point where this woman actually gets the care that needs in a well-respected facility where this woman can actually do their delivery and all those things. That is their due for such. So I just wanted to make those comments apart from the clinical aspect of it. Thank you.
Dr. Kawe, very valuable contributions that you've made. Thank you very much for coming in, stepping in to give those comments. Before I get to the questions, to the hands up that have been lifted, Prof, we've got a question here. They're asking, are there any clinical manifestations or unique tells in the HIV positive individual with COVID-19? Need to think about. Or are there any clinical manifestations or unique tells in the HIV positive individual with COVID-19? That's one question. The other one is, for those who have been on TLD for 3 months only, the new clients, are we supplying them with 3 or 6 month, multi-month tests? So 2 questions. Any clinical manifestations? Okay.
For there's no difference so far in presentation whether someone is HIV infected or non-HIV infected. Of course, there's more numbers, as you know, this pandemic was actually outside Africa. So as we have more patients with HIV infection, maybe we may learn something. So far, even in other countries, the presentation has been similar. Look at South Africa, they see the HIV. In fact, most of them have been asymptomatic. For the TLD, yes, if someone has been on TLD for 3 months, they give 3 months of TLD. They come after 3 months, and it should, we still need to give TLD or move to TLD, and the advice will be given.
think, Prof, I think the guidance perhaps that most people need to understand is people need to be also pressed in the transition.
So yes, so that's why we put the 6 months.
All right, thank you so much. Dr. Onoya, you can go ahead and give us a short question. We'll be closing very soon. There's another meeting, very urgent meeting that we need to go on to. So we're trying to do this in the next 5 minutes. So Dr. Onoya, you can speak very briefly. Then we'll have Sakala from Southern Province. All right. Go ahead.
Yes, good afternoon, Dr. Ziambo, and good afternoon, Prof. So my question came from one of the staff this morning who wanted to know what next for the staff who are pregnant. We know that working from health facilities, the risk for contracting COVID is quite high. So those of our staff who are pregnant, what is the way forward for them? Thank you.
All right, thank you very much. Sakala from Southern Province, could you please ask your question as well?
Thank you. Good afternoon, Prof, and good afternoon, Kozia, my neighbor.
Yeah.
This is Anne Mwomba. Actually, my question goes to Prof. I actually had sent him a text the other time. I'm inquiring on, there is this saying that there's a 17% of clients that may have been exposed, but then they will not have any symptoms. They'll be asymptomatic even after confinement of the 14 days, but they may be carriers. And as they are released in the community, they'll keep on shedding the virus. What is our take?
All right, thank you very much. I will ask Clarian Mwamba also to just unmute and ask the question.
Yes, Doc. Good afternoon, Prof. Good afternoon, Doc. I think my concern is on case identification for COVID-19. Particularly, I'm talking to us people in rural settings. Is there any system for courier in terms of samples? And what is the ministry doing to decentralize the testing points in the provinces? Probably my concern is that we might be reporting 35 because of low case identification. Is there anything in place to decentralize the testing points to provincial testing points? Thank you.
Thank you very much for those important questions. I will allow Prof now to pick up on.
So for the pregnant women, we do recommend just a general prevention as any other healthcare worker. Of course, I've had a few pregnant women come the consent. It's the same prevention measures which every other healthcare worker should be applying. And again, we are going to give, I think, possibly this afternoon on what type of PPE we need at different settings. The 3 levels of PPE, which we are seeing that almost everyone, every health worker wants to have an N95. Just a surgical mask is sufficient. And if you can give, if the patient is coughing, give them also a face mask as well, surgical mask. You don't need the N95. So we are giving guidelines on how to prevent us acquiring or getting this infection, but also how we prevent the patients from giving healthcare workers. So really, nothing special for pregnant women. One of them wanted to go on leave until they deliver. Now, suppose this will go on for years. Then also for those clients, yes, viral shedding will continue in certain patients. In fact, even our patients here, we have those who have been now, I think this is day 12 under our care, and they're still shedding the virus. So really, those high-risk individuals who we think that they may be at high risk, we have to do the retesting. Suppose we have more than 897 we are actively following up. So even when the samples have come out negative, after 2 weeks, we are re-swapping them as well. Then the issue of case identification and how are we doing it to extend the testing services. So far, as you know, we only have 2 testing points. We have UTH virology lab and also the Windsor veterinary lab. We are yet to receive reagents for using the probus, those equipment which are using for the viral testing. We hope that maybe next week, as early as next week, we may start using those instruments. Then actively as well with friends from the US government, the CDC, are helping us to get the cartridges for GeneXpert. As you know that now the GeneXpert can be used for diagnosis of COVID. So with those, again, once we get the cartridges, hopefully it won't be more than a month, then we can also now decentralize the testing. So we are thinking of all those modalities for decentralized testing, but also PCR lab at the TRC is being opened up as well for testing. There is an issue of using the antibody tests. We have considered that largely, but we are not moving into that. I think for surveillance that may be better, but not for actual patient management or case management, as you need a further confirmation using PCR. We are not going right now for using the antibody test for diagnosis. There's also we receive almost on a daily basis someone coming with a different tool. We also have antigen testing as well. It has been presented, and we are considering a number of these modalities. But right now it's PCR based, either GeneXpert or these other equipment which are being done.
Thank you very much, Prof. We've got 3 more questions. Luwinda, I've seen a hand, Luwinda.
Hello, good afternoon, Dr. Kozi and Prof. So I have 3 questions. Yeah, thank you. So for the TLD, do we have a sense in terms of when we think the stock status will normalize so that we go back to business as usual? And my second question is if there is any effect which we are projecting. Remember, some of these patients were on TLE. Now we switch them to TLD. We are saying let's switch them back to TLE, and then we'll switch them back to TLD. So is there any clinical manifestation which may occur because of that? Thank you.
All right, thank you. George Health Center, you have a hand raised. Would you like to ask a question?
Good afternoon, Dr. Kozi. Good afternoon, Prof. This is Dr. Chancellor. I wanted to find out, my question is a bit, I don't know, academic, if I can say that. For patients that do get infected with COVID-19 and then recover for one reason or another, do they develop an immunity towards a second infection or further infections after that? Or is there a possibility of actually having a critical infection as if they were not infected in the first place? Thank you.
Thank you very much. Lucy Zulu. Lucy Zulu.
Good afternoon, Doctor. Good afternoon, Professor.
Afternoon.
The question on whether the COVID can be transmitted to the unborn baby was not very clear.
So the question whether it can be transmitted was not very clear.
Yes, to the unborn baby.
Okay, all right.
Was not clear.
Okay, thank you. We'll attend to it. Dr. Hachizovu.
Thank you. Good afternoon, Doc and Professor. My quick question is, there's been talk about some efficacy with chloroquine, and clinical trials I think are ongoing in the US. Do we have any plans of trying this out here in Zambia on our patients? That's my first question. The second question is, these these patients that we are switching to TLE, how, if they experience an adverse event, how do they report? Do they have to come back to the clinic, or we're giving them numbers of people to get in touch with? Thank you.
Thank you very much, Prof. You may quickly take those 4 questions.
Thank you, but may I start with my classmate, Dr. Sebastian Hachizov? How are you, Aseba?
Fine, thank you, Prof. How are you? It's good to see you and to hear you. Enjoyed your lecture. Thank you.
Thank you so much. Anyway, you are in research. No wonder you're interested in the clinical trials. We are open for being included in any clinical trials which are going on. As I said earlier, WHO has extended now to us. And also there's been a concept which has been put up by ZNPHI and also the National Health Research Authority. So Dr. Tizov, let's exchange notes on what trials can be done. There's a lot besides just the treatment trials. We also need to understand various demographics, how they're affected, and even the transmission as well. We have seen some children, one child 3 years old, test positive, the mother negative. We have seen some husband positive, mother negative, but husband transmits to a granddaughter, transmits also to a daughter-in-law. So there are a lot of things that we need to understand around this, and this study. Just this morning, at the ministerial meeting, which we have daily, the minister emphasized the need for us to come up with research questions which we have to answer for. Side effects, well, if there's an adverse event which develops, of course, they have to contact the healthcare workers so that they can be advised on how best to manage that side effects, if we're bringing back the drugs. Then the normalization of stock for TLD, for now, we are thinking that possibly by July or so, 3-4 months from now, we should have normalization of the stocks. In fact, if we don't have normalization of stocks beyond September, then we'll be in trouble. In fact, if we did not again have the TLE which we have in stock, they would have been panicking a lot. So we think that by July, August, most of the countries, especially where the burden is high, they should have had reduced number of infections, such as the productions, and also airlines should now be able to move this. Mr. Lulinda, again, you asked on the clinical effect of switching. We don't anticipate this. Of course, there may be some mild side effects, and this should be managed because we are assuming that these patients are suppressed and they will be now on the TLE, similar commodity, except of course the TLD is better commodity. We expect that in terms of virologic suppression, they are already suppressed and we maintain them on TLE, they should be able to. Okay. Immunity, apparently, if one gets infected, then they recover, they can still get COVID again. I just said of a gentleman who went celebrating after recovery, and he got again infected 2 days after. So I don't know how many celebrations he's going to continue having. So there is no immunity so far, what we understand. People just need again to observe the measures which are available for us to prevent from getting. Transmission to unborn children, born babies, there have been one case, of course, reported, and the other one was at day 30. We don't know how the transmission happened, whether it was in utero or it was during labor. Also, sorry, 30 hours after delivery, yes. So we don't know whether it was in labor or it was in utero. So from this, of course, we know that there's transmission which can happen. It just depends on at what point does that transmission happen.
Thank you very much, Prof. Before we close off, there's a question here on community-based HIV testing. What is MOH guidance departments that are testing HIV communities? Any guidance on that? There's a question here.
So right now, no community-based testing. We need to, I'm sure even you've seen that even other research like Zambia, nothing to go on. Right now, our priority is to prevent the COVID infection.
All right, and then there's a question here. Kindly clarify if HIV services are being temporarily suspended. We've categorically stated that all HIV services continue. Services will continue. So I think most of our questions we've answered them. So thank you very much, Prof, for taking time to come and share with us this important information. Thank you to the network for having participated actively. Thank you very much. And hello?
Just kindly repeat on the HIV services because your network had issues. It's
okay.
That.
HIV services continue. HIV services continue. Thank you. So thank you very much. And so we have come to the end of our discussion this afternoon. We are going to have a discussion next week, and you are all invited to join in and connect as we get more updates on
Dr. Zambia.
COVID-19.
This is Dr. Mumba.
Oh, yes?
Yes, Dr. Ziambo. Would like to find out, are community activities proceeding? Things like index testing? Thank you.
All right, thank you very much. We did state that community activities have actually been halted at the moment. There are no community activities being conducted that shouldn't be conducted. Thank you.
You.
Asante sana, saving our.
So thank you very much.
Thank you.
And we'll see you next week. Thank you, Prof.